Hi, everyone. Thank you for joining us for this webinar, which is part of our series of presentations focused on applying evidence into practice. And these are these are part of our comorbidity project, which is funded by the Australian Government Department of Health and Aged Care. Off to a good start today. My name is Christina Morell. I'm an Associate Professor and Deputy Director of Treatment and Translation Research and Program Lead of Treatment and Translation Research in Complex Population at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. And I'm joined by a few members of our team today as we bring you today's webinar, which is being presented by Associate Professor Shalini Arunogiri. And if you're able to stick around to the end, Professor Catherine Mills will be facilitating the discussion session at the end of today's webinar. Before we start, I would like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting and recognise that we're across Australia today. The traditional owners of the lands I'm currently on are the Gadigal peoples of the Eora Nation, but I'd also like to acknowledge the traditional owners of the lands across Australia for everyone else who is here and pay respects to elders past, present and emerging. And I extend that respect to any Aboriginal and Torres Strait Islander people who are here today. I'd also like to recognise and acknowledge the many people with lived and living experience in mental illness and substance use, as well as their families, carers and loved ones, many of whom have so generously contributed to the development of the guidelines on co-occurring conditions, as well as our other resources. So just briefly, whether you're here live or watching the recording later, you're in listen-only mode, which means we can't see or hear you. So just to draw your attention to the Q&A and chat buttons on your screen. If you have any questions for Shalini during the presentation today, please feel free to use the Q&A button. If you have any comments or anything other than questions for Shalini, please use the chat button. And this just helps us keep track of what questions we then pass on to Shalini, or whether there's any other questions or requests for support that we need to help you with. Both the slides and the recordings for this webinar will be available for download from our website in the next few days. And I think the link for that is on screen and will also be in the chat. We have a very exciting topic today that I will hand over to Shalini in a minute. But before I do, I want to mention that you can access our webinar library and register for our next webinar on our website. And the link to do that is on screen. If you have a few minutes at the end of the webinar, please take a moment to let us know if you have any feedback or suggestions for the next in our series, and we'll see what we can do. And now it's my pleasure to hand over or introduce our speaker for today. Shalini is a clinical addiction psychiatrist and director at Turning Point and Hamilton Centre, which is Victoria's statewide centre for integrated care of co-occurring addiction and mental illness. Shalini is also an associate professor and NHMRC Emerging Leader Fellow at Monash University, with an investigator grant focusing on treatment of trauma and addiction. Shalini's work focuses on developing new interventions for addiction, including the use of psychedelic assisted therapies. And I'm so pleased that she could be here today with us, and I will hand over to her to get started. Thank you so much, Shalini.
Thanks so much, Christina. I'm just going to share my screen and hope that works out okay. Awesome. Get started. So thanks so much to the Comorbidity Guidelines team, to Christina and team for having invited me along to this. Really exciting topic, I guess, and quite topical for us here in Australia as well. Today, I'm going to spend a little bit of time kind of taking you through some of the evidence base around psychedelic-assisted therapies broadly for mental health, for substance use disorders, and then talk a little bit about that space in between around kind of co-occurring disorders and integrated care. My slides will be available as a handout later, so feel free to kind of follow along and have some questions. So just to start, just acknowledging that the work I'm presenting and where I am today as well is on the lands of the Wurundjeri people of the Kulin Nation, and wishing to acknowledge them as traditional owners of this land and pay my respects to their elders past and present, and anyone from an Aboriginal or Torres Strait Islander background with us today, acknowledging that this land was never ceded. In terms of disclosures and disclaimers for today, and perspectives as well, because I think a lot of this topic really lends itself to kind of understanding the lens with which you're using to kind of appraise both evidence, but also perspectives around implementation. So the views that I bring to this are as an addiction psychiatrist, a clinician, and a researcher. And Christina's mentioned some of my other disclosures here relevant to this specific topic. I'm a CI, an investigator on a study of MDMA for PTSD and alcohol called Empathy, which we'll talk a bit about today. Also a CI on an internal health services grant looking at psilocybin assisted therapy for alcohol and depression. And I've also been the member of the College of Psychiatrists Psychedelic Assisted Therapy Steering Committee. What that means is I've got views that are specific to looking at psychedelic assisted therapy through a clinician and a researcher lens. And I think that that's relevant in terms of how I've approached some of this evidence, in terms of how I've appraised it. None of the studies that we're on that I'm related to have any pharmaceutical or biotech sponsorship. But I think also that's also relevant to kind of think about when we think about some of the studies that we're looking at in a minute. I think in terms of kind of what we're going to discuss today, I'll take you through some of the background and some of the context, such as it is currently in Australia. I think the kind of implementation evidence we have is really relevant to how we approach the research in the space. We'll talk a bit about the evidence base, specifically looking at efficacy around the two indications for which we have in Australia, MDMA for PTSD and psilocybin for treatment-resistant depression. And then we'll talk a little bit about safety and gaps in research. And at the end, I'll touch on some of the unanswered questions and challenges for people who work in this space, for people who are trying to access treatment in the space, and we'll have some time for questions at the end. So in terms of background, as Christina was saying before, I'm director of the Hamilton Centre, which is Victoria's statewide initiative for integrated care of co-occurring disorders. And this is the premise that really sits under all the work we do. So we know that over 2 in 3 service users in drug and alcohol settings, and nearly 1 in 2 people who seek care in mental health settings have co-occurring problems. And when we think about that, that really means that what we're working with is really the rule rather than the exception. Some of the work that we do at the Hamilton Centre that I've called out here and is available on our website is around looking at training, workforce capability building, research and clinical service delivery to support integrated care provision, and really acknowledges, I suppose, that people often have co-occurring problems, and the lens that we use in terms of which door we're sitting behind, that's relevant in terms of how we're actually engaging with people, but keeping that whole person in mind, thinking about holistic healthcare provision, thinking about how we actually help the person with the problems that they're presenting with at that point in time. That's really relevant to the work that we do, because we know that the presence of both problems complicates and impedes recovery from both. If we treat one problem, not the other, what we know is that people generally don't get as better more quickly, that they often experience more challenges with that. It's also a pressing need for sort of holistic approaches that directly actually treat both problems. So there's one thing in mind in terms of how we approach screening and assessment to kind of keep these problems in mind. But also, I think, aside from that space, there's also a real need for thinking about how we offer integrated treatments that actually treat both problems at the same time. And for many people, that's really challenging to kind of access across Australia. For many people also, and this is no surprise to anyone who works in a drug and alcohol setting, we know that for most people, substance use is often a solution to an underlying problem for the people that we work with. So for people who have problematic substance use, for people who might be presenting with addiction, where their substance use has become problematic, it's often an underlying problem that's driving that could be part of a coping mechanism for someone. And so where that's really relevant when we kind of think about psychedelic-assisted therapies or just therapies that are integrated more broadly is really that attractiveness of an approach that can treat that underlying problem alongside treating the substance use, and thinking about sort of transdiagnostic treatment approaches. So transdiagnostic treatment approaches don't specifically look at whether someone has PTSD or depression or a specific diagnostic label per se, but trying to understand what those individual factors are that are driving both the problems in terms of mental health as well as substance dependence. So we can kind of think about interpersonal challenges, for instance, childhood adversity, trauma or PTSD, for instance. And so these are challenges that can help us understand how we tailor treatment for people and how we help people approach treatment in an integrated way. So I guess that's the premise by which we kind of start thinking about whether psychedelic-assisted therapies could have a role to play here. Really thinking about that sort of integrated approach or a transdiagnostic treatment approach. And transdiagnostic therapies, so psychological therapies or psychosocial therapies, address those core constructs, those core mechanisms of change. So thinking about how we change behavior at all. If you're wanting to exercise more, if you're wanting to go to the gym more, that's a behavior that you're potentially trying to change. And so what are those underlying constructs that help you actually catalyze behavior change in that way? And then on the other hand, we also have a whole range of kind of ways that we can understand behavior from a neurotransmitter perspective, from brain circuitry perspectives. So we have a biological way that we can actually understand how treatments work and how problems also work. So we can understand from that perspective what the neurotransmitter systems might be that underpin both the substance use as well as the mental health challenges. And start to think about whether these two sides of the coin, essentially, both the exhibited behavior that we can kind of work with, as well as what's going on in the brain, whether we can actually look at these as ways that we can mediate or moderate what happens for folks. And so a lot of the evidence that I'll discuss today touches on both sides of those coins. So just trying to understand how we're helping behavior change, how we're helping psychological interventions to work, and then also thinking about what are potential neurotransmitter mechanisms that might actually catalyze this change as well. So in terms of background and around psychedelics and psychedelic-assisted therapies, so PAT for short, PAT is a kind of a large hold-all term for a whole range of different types of approaches that utilize psychedelics in conjunction with different therapeutic modalities. And we'll touch a little bit on both the psychedelics as well as the therapy component. So when we think about what psychedelics are as substances, this is a family of substances that comes under this classification system because of a common effect, as well as a common area of the brain on which they work. And so in terms of some of the common sort of what we call classical psychedelics, they may have effects in terms of both desirable effects as well as undesirable effects or adverse effects, as you can see captured there. And this the slides from the Alcohol and Drug Foundation and their ADF wheel. In terms of kind of thinking through a little brief potted history, I found this really helpful in kind of understanding where this field has been. It's been on a bit of a journey, and I think where we're at is obviously 30 years past the end, 30 plus years past the end of that tale. So as you can see, psychedelics have had a checkered past in terms of both being understood as substances that might have a role to play in treating mental health problems, as well as being criminalized and sitting within an illicit drug framework across their history. So the very first kind of foray into this area was by Albert Hofmann in 1943, and now that's considered within some circles as Bicycle Day. I've taken a photo off the internet of Bicycle Day being celebrated, where this is the first intentional ingestion of Albert Hofmann, a scientist, of LSD to understand sort of the psychoactive effects of that drug. And then over the subsequent years, there's been really wide variety and different types of research on these types of chemicals in research lab settings, as well as in self-experience sort of settings. And that's really kind of halted kind of the end of the 60s, early 70s, within that criminalized kind of framework being part of the picture. In terms of thinking about the substances themselves, this is a sort of simplified version that gives you also a sense of where the natural sources of some of these substances are, including sort of 5-MeO-DMT, DMT, LSD, mescaline, and psilocybin or psilocin as well, which is the active metabolite. So you can see that there are naturally occurring components of this as well, but also what we see now, particularly in the Australian setting, is that there are also drug manufacturers that have refined or have different types, different versions of these substances, both for use in research as well as for use in outside of clinical trials, so within clinical settings as well. So the vast majority of what we now see used is not necessarily derived from a natural source. In terms of where these substances are acting, both within the brain and the body, this is a bit of an overview of that. It's quite a text-heavy slide, but I'll give the source later. And so what you can see is most of these substances and what we refer to as classical psychedelics directly act on those serotonergic systems. So the 5-HT1 receptors, the 5-HT2A receptors. And that is the mechanism by which we expect most of the sort of psychoactive effects and the subjective experiences that people have with psychedelics. That's the mechanism by which those classical psychedelics work. You can also see in terms of onset and duration of action that they vary quite significantly in terms of substances. And for most of these substances, they're relatively short-lived within the day, essentially. So we wouldn't expect to have continuing psychoactive effects beyond that one day. And so what we understand then is both the immediate kind of acute subjective effects, but also what researchers really focused on and understanding is subsequent changes that may occur outside of those acute effects as well. So are there downstream effects on other neurotransmitter systems? Are there downstream effects on how people think or behave subsequent to that one-day exposure? And so there's a whole body of literature now starting to emerge around what we understand around inflammatory systems and other systems that actually may relate to this as well. And so kind of quickly giving you a bit of a highlight, there's a really sort of somewhat reductionist picture on the left that kind of shows you something from The Economist that highlights the different neurotransmitter receptors that these substances impact on. And as you can see, the 5-HT2A system is a serotonin system. It's a primary serotonin receptor there that's being circled in the dark blue. And then we've also got the 5-HT1A and 2B systems that also are impacted on by a couple of these chemicals. On the right, you can see a more complex kind of version of this that also looks at how this might have an effect on a whole range of different mental health symptoms, including kind of thinking about depressive symptoms, about memory sort of systems, around PTSD, for instance, or alcohol use. Until this slide, you wouldn't have seen me discuss MDMA because MDMA is not considered a classical psychedelic. And I'll tell you a little bit about what that is and why. But you can see the vast majority of sort of classical psychedelics are acting or thought to act primarily through that 5-HT2A system. Ketamine is also considered within this class, but also has direct action specifically on the NMDA system, the glutamate system. So when we come to MDMA, and a lot of the research that's been conducted here in Australia and internationally considers kind of MDMA within this psychedelic category. MDMA is not a classical psychedelic because its actions are actually at the transporter. In the previous slide, you saw that SERT, the SERT transporter. And so it has downstream effects on serotonin levels, but doesn't actually directly act on that. In fact, the way it often acts is more as a stimulant chemical, because it also blocks the DAT, the dopamine neurotransmitter system, and it promotes release through that system also of oxytocin. So MDMA is quite an interesting chemical. It's got a few different ways that it acts in our brain and our body. And through the literature and through people's experiences have been described more as an entactogen or an empathogen. So it has these downstream effects on behavior that are not necessarily classically psychedelic. The acute subjective effects are also not classically psychedelic as well. So when we think about psychedelic assisted therapy, holding that in mind in terms of these array of different types of chemicals that produce different sort of effects, the crux of this model is the conjunction of that chemical with therapy. And so there are different models that are utilized, but largely that crux of that model is the psychotherapy is offered in with the addition of the medicine, and the idea that there's the medication that may actually enhance the therapeutic process. And that's a really important kind of difference, I suppose, with how we understand other medications that we might use for mental health disorders or substance use disorders, where there isn't necessarily that relationship between the medication that we're using and the psychotherapy. So largely within sort of psychedelic assisted therapy models, what we're looking at is usually a 2 to 3 session dosing model where people might have these one-off exposures to the substance rather than a continual maintenance model. So for instance, in an antidepressant model where someone might be taking a medication every day, what we're seeing here is these one-off exposures, sometimes just one, sometimes 2 to 3 over the course of months, where we're understanding that relationship between the dosing exposure, what might be some biological effects as well within the brain and the body that might happen after that exposure, and then also what that means for therapy that occurs before and after dosing sessions as well. And so that's a really important part in terms of how we relate to the evidence as well for the space, and trying to understand the whole of it as a package, rather than trying to necessarily be able to draw out to any extent the active effects of the substance alone or the active effects of the therapy alone. So that's a really kind of emerging space for the research evidence to try and tease that out. In terms of some factors that are put forward as potentially influencing a psychedelic experience specifically, and this is the acute subjective effects that may arise for that individual. This is a model kind of thinking about both literature and people's self-experiences and self-reports around that. there's a whole range of different reasons that this is very different from taking the substance in a recreational setting. So for instance, every part of that process in terms of preparation, the specific type and choice, the dosing, the amount, the route of administration, and then what you'll often see referred to as set and setting, so those numbers 5 and 6, around where the person's headspace is at, what they're intending to get out of the experience, and then the environment in which that experience is occurring. That conjunction between set and setting is pretty critical to kind of understanding what that psychedelic experience is like for an individual, and also what they're likely to learn from it in terms of integration as that next step. So all of these elements are quite distinct from, for instance, recreational use in a recreational setting. And so that's an important kind of factor and to think about, and I think an important part of how we describe what people are consenting into in terms of both clinical as well as clinical trial settings as well, trying to understand those elements that are quite different. In terms of kind of thinking about those psychological mechanisms that might occur and might change as a result of psychedelics working, I think here I've kind of flagged that this is how they might work. Suffice to say, before I get to the research evidence, is that we don't necessarily conclusively know whether they do work, first of all, and also which mechanisms here conclusively what is likely to actually promote change for different disorders. So this is a lot of the research being done right now, is to really kind of break this down a little bit further and understand which of these processes are, first of all, actually specific to the psychedelic effect rather than necessarily just the therapy, but that conjunction of both. But also understanding, are these processes kind of active ingredients to kind of mechanisms of change for people? As you can see, these different kind of domains might be really relevant for different mental health and substance use problems. For instance, when we're thinking about MDMA for PTSD, we're thinking about a whole range of systems on the right-hand side of that screen. It's right for me, I think it's right for you. So social processing systems, negative valence systems, arousal systems, for instance. So particularly how people think about traumatic memories or traumatic spaces, for instance, so that fear and threat appraisal, being able to go and approach those memories in a way where the threat appraisal is really lowered, being able to kind of connect with things in a much more open way and take perspective, for instance, and also the social processing systems, so the capacity to be able to connect with others, which is a really kind of critical process in recovery for most people from substance use as well as for PTSD. So these are the sort of systems that we're really interested to understand whether psychedelic assisted therapy has a direct impact on them, and also whether they can catalyze change through the ongoing therapy that we might be doing. In terms of kind of thinking about how specifically MDMA might work for PTSD, I think I've talked a little bit about that fear appraisal, and also kind of thinking about how memories are consolidated or reconsolidated within our minds. And enhancing that process of learning and that process of flexibility in learning, which continues through therapy. So there are some neurotransmitter systems that may be affected, including brain-derived neurotrophic factor, or BDNF. So there's some theories around the fact that these might be direct effects, but also some theories around this being downstream effects. But also for anyone who works in kind of drug and alcohol treatment settings, you kind of see that the last three kind of components are really key to effective counseling and effective therapy of any type. So thinking about openness, self-compassion being really kind of key, and also the therapeutic alliance of the relationship between the counselor and the client. These are kind of key factors that have been drawn to predict change and predict recovery in existing psychedelic assisted therapies, but also really core transdiagnostic reasons why people get better from standard therapies too. So when we think about kind of memories and how this plays a key role in how we treat PTSD, these are some of the theories around some of the systems that might be affected by MDMA. Again, here, this is just to give you a sense that there is a lot of literature and a lot of work being done here to try and understand this a bit better, many of which are in animal models and in mice. But I think in terms of kind of understanding the active role that this has to play in humans and people in recovery in our treatment settings, I think there's still a lot more to learn in this space. And then when we think about sort of change in self-compassion, as I mentioned before, this has been a key predictor in MDMA-assisted therapy trials today of people getting better. And you can kind of see that change in self-compassion being really key and being really core. And this is in PTSD-specific treatments with MDMA-assisted therapy. It's not in clients with PTSD who also have substance use treatment. So you can see that this might have a real role to play within a substance use cohort, where this is a core construct that we're really trying to change for people in counselling. So moving on to kind of thinking about what's happening in Australia, what has been happening for the last couple of years as well. Just giving you a bit of a sense of the context, and it's a really interesting space to work in, both as a clinician and a researcher during trials in the space, because we're a unique environment internationally in the sense that we've got both trials and implementation of clinical processes at the same time. So people might be aware of some of the background to this space, and I've just picked out a couple of articles, both research and public domain articles, popular press articles, to kind of give you a sense of some of the background to some of the discussions that we're having today. The original decision around scheduling of MDMA and psilocybin was in October 2022, and the TGA had a look at whether the evidence for these indications was sufficient, and initially chose not to schedule these medications or down-schedule them. In February 2023, there was a change in that decision. And also what's key here is that there was quite a short timeline for sort of implementation of changes to bring about access to clinical treatments. So for many types of medication decisions, this would be a very short timeline. For this specifically, it was particularly short in the sense that there weren't already kind of treatment spaces that were set up. There wasn't necessarily any guardrails or clear models to sort of follow. And so some of the research evidence too, there's some systematic reviews and some opinion pieces around that time, around concerns from the research and academic kind of field around the quickness of this decision. But nevertheless, the decision went forward, and we're kind of, almost a couple of years down the track. We've had an authorized prescriber pathway since the 1st of July 2023. So this allows psychiatrists to apply to this authorized prescriber pathway. Psychiatrists need to follow a set of guidance that the College of Psychiatrists has set out in their clinical memoranda. And that allows psychiatrists to then get approval to be approved to offer these medication treatments. And that's only for these two indications and these two substances within a clinical pathway. So that's psilocybin for treatment-resistant depression and MDMA for PTSD. So these two indications have the majority of sort of evidence at the time, had the majority of evidence, and there still continues to be more evidence for these indications than for other indications. There are extensive kind of information both about the clinical memoranda and the TGA guide on their websites. So if people are interested, including if you're a clinician and you want to provide information to your clients about this, there's some really good information on the TGA site around this. And so in terms of where we are now, there are several private clinics operating across Australia, largely within metropolitan settings and largely on the eastern seaboard, so mainly in Melbourne and Sydney. There is a clinic in Perth as well. And the models within private practice vary, but mostly they're 1 to 2 sort of exposures, so dosing sessions, usually in a package of care, which includes assessments as well as therapy that wraps around those dosing sessions. In terms of that model, as I was saying, it varies, but largely kind of focuses on that sort of package of care. There are also several clinical trials across Australia, and that includes sort of trials across several different indications beyond treatment-resistant depression or PTSD. So those currently, in terms of those two indications, we've got 4 ANZ CTR registered trials currently of MDMA, and 8 registered RCTs of psilocybin today for any indication. So these studies, no doubt if anyone's been aware or been involved in studies like this, they take a lot of time. They're quite intensive kind of studies. So in terms of where that literature is likely to be at, it's going to be a couple of years at best down the track before we get sort of results from some of these studies to try and understand what the evidence base looks like. And that's in an Australian setting. Clearly, there's a huge amount of research internationally as well in this space, and that's really grown in the last couple of years. But what we see here, I think, is also relevant to kind of understand what this context is in terms of how we help our clients understand how they access care, and also how we make informed decisions and informed consent for clients who might be accessing both care as well as clinical trials. In terms of kind of just giving you a sense too, if you're interested in this area, there's whilst we're all waiting for the research evidence to come out, I think there've been lots of studies where we have been asking each other what we think. And so within the Australian context, there have been several sort of survey-based studies and focus group-based studies to really understand kind of preferences, perceptions, attitudes. Here I've picked up a couple on this slide around consumers. The next couple of slides highlight clinicians and policymakers and politicians as well. So this is an area that clearly is of relevance and interest to a really wide variety of different groups of stakeholders. What we're seeing within the surveys that have been conducted with consumers are largely a relative openness to kind of considering this as a treatment option, but within the consumer space as well, really flagging and highlighting concerns around safety and whether safety has been thoroughly understood. And then within some of these studies, there's a capacity to drill down what's likely to influence individuals' kind of perceptions and attitudes. And often it's either people's own self-experiences with psychedelics, but also what people access within popular press or media. So that's also a really important kind of consideration in terms of the climate or environment in which we work. In terms of clinician perceptions and attitudes, there is both of these studies found that there was a relative openness and relative interest as well, particularly because these substances represent a new sort of pathway of care for people, quite different from the types of medication options that have been available to people to date. But what you also see there is, again, those concerns around safety and concerns around the research efficacy as well, as to whether we know from research evidence as to whether these substances are likely to be effective or not. And also some questions around what we don't know. So those gaps in research evidence being flagged as well. And then when we think about stakeholders in relation to kind of policymakers and politicians, I think that this is an interesting read for anyone who's interested in this space. I think what comes through here is also concerns from politicians around the level of stigma that relates to these types of substances because they have been illicit in most climates, in most countries to date. And so the level of stigma that relates to these substances as to whether or not people are going to appreciate them as potential therapeutic mechanisms as well, which is a really interesting space to kind of think about when we work in drug and alcohol more broadly, and understand the level of stigma that our clients face for the substances that they use. So it's a really interesting read from that perspective. And drawing that to a close, you kind of understood hopefully the environment in which this work occurs. Now to talk a little bit about research evidence and research challenges. To start with, off the bat, there are some real challenges to conducting research in this space. Firstly, the question of functional unblinding. There's a cartoon there that I think hits nail on the head a little bit in terms of some of the challenges for research in this space. The way in which our evidence-based medicine sort of system, the holy grail of that really is a randomized double-blind controlled trial, where we have a placebo-based substance and then an active substance. And the premise really there is that people aren't able to kind of guess their treatment allocation, so that we're kind of pulling out some confounding factors that come from people knowing what they're on or believing that they know what they're on. Unfortunately, in these sort of trials, because of the acute subjective experiences that people have with these substances, the vast majority of participants in recent trials have really been able to guess their treatment allocation, and that's down to those acute effects. But also more broadly, there is a whole element around expectancy. So you saw some of the articles that I snapshotted before. I think if you worked in the US, for instance, there were many more sort of documentaries and popular press and a lot of hype around these psychedelic substances being sort of the panacea or the cure-all for mental health. And so I think what that brings into a clinical trial environment is really kind of thinking about the biases that people might bring in terms of their presupposed effects of these substances. And so the expectancy effect is a really important kind of thing for us to kind of think about, try to calibrate within research, also try to measure and control for as much as possible. And so for more recent research, I think there's been a lot more work been trying to kind of institute sort of rigor around how we speak to people about the substances, that they're going to be receiving, about what expectancy is at the baseline, but also how we can shape that through the trial to really understand what is an active effect of the substance, an active effect of therapy, and then overall what an effect size looks like there. And then in terms of generalizability, this is another key challenge where we know that in many of these kind of clinical trials, that less than 10% of potentially screened participants make it onto these trials. That's for a whole range of reasons. I think as a field, this is still very early days for this field. And so we're trying to understand what works before it broadens out into generalizable kind of clinical populations. But that is a real challenge when we've also got a framework where people can also access this already in clinical settings and in routine clinical care. So I think, keeping that in mind, that the research evidence really reflects a sort of narrower group than what the general population is. And that includes definitely people who have active substance use disorders. Many of the existing trials may not necessarily include that population within existing trials. So we have to think about, does this research evidence extrapolate to the clients that we see as well? And so I'll just move to kind of thinking about effectiveness and what the research tells us in that space. And I've just talked a little bit about within the mental health space, treatment-resistant depression and PTSD, but there are a whole range of other studies that look at specific disorders that are really accessible. So in terms of psilocybin for treatment-resistant depression, actually for both MDMA and for psilocybin, it's worth saying that there are probably more reviews and systematic reviews and meta-analyses than there are actual studies to include. And it reflects that huge amount of interest in this space and trying to understand also how to do this research better. I think so there's been a lot of commitment to trying and collating, consolidating evidence. Within this space within psilocybin, we know that this is about just under probably 10 completed randomized controlled trials to date for this indication. The most recent systematic reviews collate about 450 to 500 patients. And overall, there's been a general sort of a signal in favor of psilocybin. But really, having said that, there's been very limited kind of medium to longer term data in terms of whether that's sustained. And all of this evidence is really with some major caveats around this moderate risk of bias. So touching on those points that are already made before around sort of blinding concerns, generalizability concerns, expectancy effects. So if people are interested to read, this is the visual abstract from the BMJ review, which had a revision done as well. There was some feedback around how they analyzed the specific trials as well. So this is the updated version of that review that came out earlier this year. And as you can see, if people are familiar with these forest plots, the plot in the middle of your screen highlights where that evidence of effect is, and on the right-hand side is where that would favor psilocybin, whereas on the left-hand side, that 0 mark would be where there's no effect and then favors control. And you can see there's some different doses as well that have been looked at. There's some really interesting studies kind of playing with that and kind of trying to understand whether a higher dose is likely to have a better effect or not. So that link is there if people are interested to look. The next kind of space in this area is MDMA for PTSD. And again, several systematic reviews and meta-analyses have been done in this space. What I've included here is an abstract from the most recent review that's done in Australia specifically by Aline Yong and colleagues, and it looks at a whole range of different systematic reviews. So this is an umbrella review of systematic reviews. So really high level of sort of research evidence. It means that the rigor of this is really helpful. And it also includes kind of looking at biases or quality of individual studies that were included in those reviews as well. And so, the research evidence is there to have a look at. Really, the top line notes are that overall that these studies that have included really have had a high level of risk of bias. So that means that the certainty with which we can find those effects is quite limited. But all reviews have included sort of that 1 to 3 sessions of the 50 to 125 of the MDMA assisted therapy. And largely this has been done with individuals with PTSD rather than with any other comorbidities. The kind of outcomes reported in these systematic reviews that were included in that umbrella review look at also the efficacy, just drawing everyone's attention. There's a lot of detail on this slide, but drawing your attention to the efficacy, that third bar, and highlights kind of the types of changes in PTSD symptoms, types of changes also in sort of remission from PTSD, and changes in sort of depression and longer term outcomes. So these are all kind of really promising early sort of signals that this might be having an active effect. Those effect sizes are quite good, particularly when you look at remission rates, so no longer meeting PTSD criteria. But when you sort of look under the hood, when you start to, kind of understand individual studies, I think that's where we start to think about what's up on the top, the study characteristics, the risk of bias sort of questions that are really relevant to how we understand and appraise that evidence. And also think about how we need to create sort of new research that might address some of those gaps that are arising. In terms of safety, that's also a little bit here around safety, and I'll talk a little bit about safety overall for MDMA and in PTSD. I think MDMA and psilocybin have a very different kind of profile, and I think the safety risks, I think safe to say that the safety risks are higher and sort of more of a concern with MDMA than they are for psilocybin, more broadly speaking. But I think in terms of how we approach that, it's also to understand what clients might be presenting with when they come into treatment. As I mentioned before, this is quite a narrow group that gets into studies. So trying to understand how this relates also to the client groups that we might see in the clinic. So when we come to substance use disorder, there's much less evidence in this space. And as I mentioned before, people with substance use or substance use disorder are often excluded from the mental health trials that have specific indications. Many of the studies to date that are included in this recent review are sort of uncontrolled, sort of small studies where people might have, 5 to 10 people in a pilot. Also, a lot of survey studies where there's self-reports from people who might be having self-experiences or trip sitting off facilitated experiences or non-medicalized setting. And all of those are not transferable necessarily to understanding whether this works in a clinical environment or in a clinical population. Trials for specific use disorder indications include at the moment psilocybin for alcohol use disorder, ketamine, again for alcohol, and psilocybin pilots for methamphetamine use disorder. In terms of that landmark study probably to date that's been done with alcohol, just drawing people's attention to it, and you can go off and read up about it if you're interested. But this has been the biggest study to date that's been done and published on alcohol. And this was not looking at any kind of comorbidity, so it wasn't looking at depression or any other symptoms that people might be having, but primarily for alcohol use disorder. The population as a group was probably a lower in terms of how much people drank and how often, lower than what we would see for maybe other types of alcohol use disorder trials. But broadly, other than that, I think some really interesting and key learnings to be had from this study, the Bogenschutz study. So in terms of kind of drawing our attention back to thinking about integrated care and what those challenges might be for us in this space, and we'll have some time for questions shortly. So if you've got any questions, pop them through at this point. I guess when we think about integrated care and those comorbidities, there really haven't actually been any completed studies internationally to date. There's been some, to my knowledge, and I think there've been some really promising indications. Alcohol and PTSD, which I'll mention our study in a second. Also alcohol use disorder and depression, and methamphetamine use and depression. So there's some really good reasons why this might be helpful for those comorbid indications. But really there haven't been any completed studies to point us in any direction at the moment. It's a major gap. The study that I'm lucky to be part of is the empathy study, which has been conducted both in Sydney and in Melbourne. It's been led by Kirsten Morley at RPA and University of Sydney. And the site in Sydney is led by Paul Haber, and the site in Melbourne by myself. That picture on the right is our great team who are based here in Melbourne for the study. And there's a whole range of investigators really lucky to work with across Australia. The study I'll tell you a little bit about is really kind of both that mix of what's an evidence-based treatment for PTSD, for which we already know works for PTSD and alcohol use disorder, COPE, which is a prolonged exposure type therapy. So it's 12 to 14 sessions usually, involves kind of a really structured, manualized way to help people kind of process and think about traumatic memories. And then it's also got relapse prevention built into that model. And what we did was look at the addition of 2 MDMA dosing sessions with that underlying construct of thinking about how this would assist people to be able to catalyze the exposure-based mechanisms that they're doing within the COPE model already. So it's that really kind of conjuncture between thinking about both the medication intervention and the therapy. It's a total of 14 sessions in this trial, including those sessions. And the primary outcome here is really around PTSD severity and alcohol use disorder severity. So that trial is recruiting both in Sydney and in Melbourne. So if you're interested, please reach out to ourselves. I've got my email address in the end. We can point you in the direction of the recruitment forms and things of that study. But early days for this study and for the field overall. I think what we've really learned from running this study so far, it's been a really rewarding study to be involved in. As you've seen, the research evidence is changing so quickly, so we've been able to kind of try and reflect a lot of that in the therapy protocol for the study, and also really kind of helps us understand, I guess, what we look at when we think about therapies overall in an integrated care context, how we understand people, how we understand kind of mechanisms of change that might be working in therapy. And for us, it's been a really natural and really helpful mix of both bringing this really unstructured kind of psychedelic assisted therapy space to a really structured evidence-based treatment. Whilst they might feel like they're quite different within the conduct of the study, I think it's actually been really rewarding and interesting to kind of see how we stitch that up together and bridge that. So finally, drawing this to a close on kind of thinking about safety and adverse effects. So this is still an unanswered question, I think, particularly in populations that are outside of clinical trials. So the current studies, as I mentioned, have been really quite narrow. And within those settings, largely these medications have been very well tolerated without any evidence of kind of sustained or longer term effects. But those are the medications themselves. When we kind of think about the therapy intervention as well, we're really trying to understand as well what are medium and longer term signals here, and we're also really kind of concerned and interested in whether these have an impact on kind of medium and longer term side effects, psychological side effects and adverse effects as well. And so it's really important that both clinical trials have follow-up data to be able to understand this at 6 months, at 12 months, at 18 months down the track, but also that data that's coming from clinical pipelines through the registry and TGA data during this rollout is going to be really critical to inform that safety signal in a non-clinical trial population. So in general participants who might have lots of comorbidities, who might have other things going on that a clinical trial population might be different. In terms of side effects, just flagging this study, which is probably the most complete kind of study of psychedelic, of MDMA-assisted specific side effects. As you can see, there was a higher odds of these types of side effects occurring. Some of these are related directly to MDMA. Most of these effects are sort of transient and short term, but also in this paper, what the authors were really pointing out as well was that there's a sort of lack of a very systematic or systematized way to kind of identify and follow up some of these side effects. So really, really important for both researchers and for clinicians offering this type of therapy to have really systematic ways of looking out for these problems and then for capturing that information, because that information is critical to how we design treatment going forward. And so finally, in terms of those gaps in evidence, there's some major gaps and limitations, as I mentioned, in existing evidence. There's still very little to no evidence coming from an Australian context to date, but there are really several trials either in planning or currently underway. So the space is going to look quite different in a couple of years. And I guess whether that road's a straight road from research to implementation, I guess we've got this context where we've got both research and implementation at the same time. So during that space, I think that's a major challenge in sort of providing really well-informed consent to clients, to participants as well, whilst those gaps in evidence remain. And so it's really important kind of people are cognizant of that and where this is at in its journey. And then also thinking about safety in that absence of really longer term follow-up data, and understanding how these treatments interface with conventional or other treatments or maintenance kind of treatments or approaches. That's also relevant in kind of what we think about in the longer term. There are some major challenges in implementation, particularly because the current model, which is based on the very sort of initial phase of sort of research in this area, may not be widely implementable or accessible. It's a very labor-intensive model. It's a quite intensive, both for clinicians as well as for clients. And so it might not be a model that's going to be cost-effective or accessible. Doesn't exist within public services yet. And so finally, kind of bringing us to a close, really throwing those two elements in mind, integration is a key part of kind of psychedelic assisted therapy. And it's really the task of sort of making sense and making meaning of what insights people might have and drawing that into the real world. And then for us, I think as researchers and clinicians in the space, kind of thinking about implementation as that process of really gathering that evidence, understanding perspectives, including kind of consumer perspectives of people who have been through clinical trials of these psychedelic assisted therapies, and then applying that and improving the way we do research as well. So thank you for listening. I'll hand back to Kath.
Thanks so much, Shalini. And we do have a number of questions because it's such an interesting and topical area. So I might just jump straight into them and we can see how many we are able to get through. If I don't manage to get through all of them, I'm just wondering, would you be happy for us to pass them on to you to provide some responses to that we can then upload to the website?
Yeah, totally. That's great.
Awesome. Thank you. So just the ones that have come through at the moment, a question about what are the effects on other comorbidities like depression, substance use disorder, personality disorder, and particularly borderline personality disorder?
Yeah, it's a great question. The initial studies have largely been for just those two indications and solely those two indications. So the early research have looked at, squarely at PTSD, really not looking at what those other comorbidities might be or how they change. And then also with depression, treatment-resistant depression, looking at depression and not necessarily looking at what else is happening for people. So we kind of don't really know yet. And I think when it comes to personality disorder, there's a really interesting space in terms of understanding how these treatments might offer really transdiagnostic ways to work with personality. And I think to date, the vast majority of trials, probably until maybe 1 year ago, have explicitly excluded people with personality disorders from the trials. So what that means is we have no idea yet in terms of whether this does or doesn't work. And I think also that the same way I say we don't know if we've got efficacy signals, we also don't know what safety, adverse effect profiles, what risks are for people who haven't been included in studies today. So for both people with substance use disorders as well as people with personality structure questions and diagnostic labels, I think for those groups, we don't know yet. And there is that newer wave of research now currently coming through. There are a couple of studies internationally starting to look at personality disorder indications. And so it's really important we kind of keep an eye on those and try and understand both efficacy and safety through that.
And I think it's a really good point as well for, I guess, us researchers is really thinking through in our criteria for entry into studies. Is it essential to exclude people based on those things? Or should they be more open up to people that are more likely to be in clinical practice, what people are seeing? Also, a question about in relation to the services that are being provided by private practitioners, whether or not you have any impression about whether it reflects fidelity to psychedelic assisted therapy models like those that have been undertaken in research contexts.
Yeah, that's a really good question, because I guess like the way we often understand fidelity, like say for instance in our study that I mentioned before, we have overarching, we have a relatively manualized kind of structured type of therapy. And so when we measure fidelity in those types of therapies, we can kind of draw together what's happening in the session versus what might be happening in the manual, for instance. When we look at this space, there are quite an eclectic, broad mix and range of different types of therapies that can be offered in that psychedelic assisted therapy fold, which that makes it challenging to kind of understand what is actively going on and how that matches with what we consider, I guess, fidelity overall. So I think this is particularly true for the MDMA assisted therapy space for PTSD specifically, because there is just such a mix of different types of therapeutic approaches that are being utilized. I think within private practice settings currently, both in Australia, but more so internationally, there again is a really broad mix of different approaches. So it's hard to kind of distill down what are the active ingredients, what's actually going on, and does this also match what we know works for this indication in terms of an evidence-based therapy? And I think there's still a paucity of sort of studies kind of mapping that.
Yeah, and it's interesting because it seems like sometimes with the studies, people lose sight of the psychedelic assisted part, that it's the psychotherapy that is still the main active component. And it's just the medication that is thought to potentially assist people get maximum benefits from that.
And we really want to measure and understand the therapy. Exactly. Yeah.
And a question of, not sure if you'll be able to answer this broadly, but with the research that's been conducted, do you know if there's any been on specifically on Indigenous populations, or if there has been some aspect of planning in relation to Indigenous populations in those projects.
Yeah, I'd say, I guess, just speaking to the Australian evidence, I don't think there have been any, and someone in the chat might be able to correct me if I'm wrong, but I don't think there have been any specific studies actually purposively sort of recruiting and actually specifically addressing sort of Indigenous populations. Internationally, I think, particularly in the US, there have been a number of studies now kind of being pulled together that I don't think they're necessarily recruiting or underway yet. So this has been a slower kept, I think, to get off the rank. I think there's another body of literature, particularly from a sociology and ethnography space, trying to understand what those key elements are within Indigenous practice using many of these psychedelics, many of these substances. What are the key ingredients, kind of what happens in those rituals and what happens for communities, and trying to really understand that in a more rich and deep level.
Yeah, no, that's great. And definitely an area that is always in need of further attention and research. There are a few other questions, but I know I do have to hand over to Chris for wrapping up. But I guess I did just want to make one comment on a comment that came up in the chat as well, which was around, sorry, I've lost it now. Oh, Jeff was mentioning about, talking about the evidence that in relation to psychotropic drugs sold by Big Pharma, and whether or not they actually work and don't have side effects, and can sometimes be worse than the condition itself, with the efficacy rate of most antidepressants being 20%. And I think I just kind of like to highlight that point in the sense of it's kind of like a cautionary tale in essence, because it was, you know, similar to antidepressants when they first came out as well, and done in some trials where you would see large effects. But then only later in the randomized controlled trials that were done more rigorously did you start to see that those effects were a lot smaller. So I guess considering that we're in that sort of same space as you were mentioning before around people potentially seeing it as a panacea, and we see in the media and literature kind of the more extreme ends of the spectrum of this is really awesome and it's going to, you know, fix everything, to no, this is really terrible. Whereas it's probably somewhere more around the middle, as with many other medications.
And I think that's a really helpful comment to kind of think about the, I guess, the comment around Big Pharma, because I think it's also important to understand that there's a massive industry around psychedelic assisted therapy. And this is a highly invested in space right now, and invested in terms of venture capital and other investments. And so this is also Big Pharma by another name, and so I think maybe it's slightly smaller but still big. So it's important to kind of understand, I guess, industry influence in this space again, and the research that we read and critically appraise as well.
Thanks, Shalini. There are more questions. As I said, we might just send those through to you and then we'll pop them up on the website for people to look at later, but I'll hand over to Chris. Thanks, Chris.
Thank you. And thank you, as Kath said, I know that there are some more questions that we didn't get to, but we will send those through to Shalini. And just before we wrap up, I wanted to let you all know that you can find out more information about our guidelines, which this webinar series is linked to, and our other resources at our website there on screen. And for you practitioners out there, we are really excited to let you know that we have an online community of practice, which is also funded by the Australian Government Department of Health and Aged Care, which is very fresh. This is for professionals in Australia who work with people who experience co-occurring alcohol and other drug use and mental health conditions. It's free. You can find out more about it and register to use it by clicking on the link on the screen there, or navigating through our homepage. And I just wanted to thank you again for having joined us. And of course, thank you, Shalini. If you're interested in having a look at our library of previous webinars, watching this one again and catching up on anything that you might have missed, or sharing it with your friends and family and colleagues, and registering for our next webinar, you can do that on our website. Our next webinar is scheduled for the 3rd of June, and that will be with Dr. Eddie Mullen, and he'll be speaking about neurodiversity and substance use. But until then, thank you again for joining us today. Thank you so much, Shalini, and please, everybody, enjoy the rest of your day. Thank you.